closer to that microphone? No. Okay.
I think so. This whole room, when he closes the door, the whole room is mic'd. So you actually have to be kind of quiet.
Okay. Yeah.
You're on.
Good afternoon and welcome to the OHA COVID webinar series for healthcare providers. This is Ariel Smits. I'm the Medical Director for the Health Evidence Review Commission at the Oregon Health Authority. I'm one of the people who regularly does these. Unfortunately, Dr. Tom Jean, who's our epi specialist, well, fortunately for him, he's on vacation this week. So we have had the good fortune of having Melissa Sutton from the Epi Division join us. And unfortunately, Dana Harganani wasn't able to join us either. So welcome, Dr. Sutton.
Thank you for having me.
And today, we will go through our usual COVID-19 situational update and give you some updates on testing shortages, as well as give you some information about our revised personal protective equipment guidance for resource-constrained environments. Give you a little update on our Remdesivir situation, kind of a reminder about masking in healthcare situations, give you a little bit of updates on some literature that's been published in the last week or two, and answer a few of your questions. And remember that you can ask questions through our chat box. Unfortunately, you can't chat with each other with our setup here, but we will see your questions. We may or may not have time to get to all of them. If we don't get to your questions during today's presentation, we will try to answer them for our next presentation. So Dr. Sutton.
Yes, so I'm going to just start with a situation update, the COVID-19 pandemic in Oregon. So as of July 14th, we have had almost 13,000 total cases. Of these, a very small proportion, 643, are presumptive cases. Just to remind the audience, presumptive cases are cases who have symptoms compatible with COVID-19 and have a known close exposure, but do not yet have a positive test result. Often these presumptive cases are ultimately reclassified as confirmed cases. And then as of July 14th, we have had 244 deaths. Slide forward, please. So for the week of July 6th through July 12th, we had more than 32,000 COVID-19 tests reported to the Oregon Health Authority. During this week, we had more than 2,000 new cases. This represents a 7% increase from the previous week. If you look at the graphic at the bottom of the screen, this is Oregon's epidemic curve. This is the number of cases reported per day. You will see that the curve falls off at the far right of the screen. Unfortunately, that is not a dropping case count. That is simply lagging data. Our overall percent positivity for our tests has increased to 6.2%. In general, 5% is considered a benchmark for having the pandemic under control. So rising above 5%, unfortunately, is not a good sign. And in general, the rise in cases that we are seeing is largely felt to be a result of widespread community transmission. Here we see our EpiLink trends by week. So these are the proportion of cases that we attribute to either clusters, households, outbreaks, or sporadic transmission. So the orange bar is the most important bar here. We see that, early in the pandemic, we had a rise in March in sporadic transmission. This tapered off and outbreaks began to contribute the most cases. Unfortunately, over the last several weeks, we have seen a dramatic increase in sporadic transmission. Sporadic transmission is essentially synonymous with widespread community transmission. It's a smaller and smaller proportion of cases attributed to outbreaks and clusters at this time. Here again, this is just another way to visualize sporadic transmission. This is the percentage of cases that are not traced to a known source. And we see again that this trend, it rose in March and then it declined for some time. Unfortunately, it's now been increasing for several weeks. Here we see our COVID-19 cases by age group. It's difficult in the early pandemic to sort of see who's got the highest case counts here. But we see a clear divergence as our cases have risen recently. We've seen the 20 to 29-year-old cohort have the most cases, followed by 30 to 39-year-olds, and then 40 to 49-year-olds. Recently, we have seen 10 to 29-year-olds surpass 50 to 59-year-olds. So we are seeing increases in pediatric cases across the state, and we are also seeing the cases rise in our 0 to 9-year-old group. This is a graph that describes our active monitoring or active surveillance capacity. So one metric that we think is important in outbreak epidemiology is the proportion of cases that we attempt to contact within 24 hours of receiving their case report. 95% is the benchmark that we have set in conjunction with the CDC, and we are largely meeting that metric. But I do want to point out that this is attempt to contact and not making actual contact with cases. In this day and age, it is very difficult to get people to answer the phone, and so our case investigators often have to call cases and their contacts many times in order to reach them.
Just, I know this question came up with the last time we presented this slide. This is the contact with the actual positive patient. It's not the full case investigation for all of their possible contacts.
This is actually just an attempt to contact the case. So if a case investigator dials the telephone and leaves a message for a case, this metric would be met. So it is not the complete case investigation or contact tracing piece. Here we see our COVID-19 hospitalization trends. Again, unfortunately, we are seeing a rise in hospitalizations. This is broken into non-ICU admissions and regular admissions. ICU admissions are visualized in blue at the bottom of the graph, and regular admissions are visualized in orange at the top of the graph. So in general, we see that since mid-May, we have been seeing increasing hospitalizations without a huge jump in increasing ICU admissions. We are seeing increasing ICU admissions, but because so many of our cases have shifted to the younger age groups, we are not seeing the same hospital capacity increase that we saw in the early pandemic.
Could that also possibly be due to changes in how we're trying to get people to not be put on ventilators, or is that just all kind of conjecture?
I would say it's largely conjecture. I think, so this graph is tricky because ICU admission, some healthcare facilities actually have COVID units that are located in ICUs. So it's not necessarily even synonymous with disease severity. So it's kind of difficult data to parse.
Now we have one question that's come in from the chat box. When the reported COVID deaths that we have on our metrics, are those deaths from COVID or deaths with COVID or both?
That's a good question. So we count COVID deaths a few different ways. So when a death occurs in the community, it is counted as a COVID death if on the death certificate COVID is listed or any code related to COVID-19 illness is listed. For patients who have been admitted to the hospital, a death is counted if the patient passes away during that hospitalization. Even if they were admitted for, let's say, a broken hip and found to incidentally have COVID, we would still count that death. We also examine patients who have been discharged from the hospital. We look at the 60 days following hospitalization, and any deaths that occur in patients who have been hospitalized with COVID-19 during the 60 days following discharge, regardless of the reason for death, are counted as COVID-19 deaths. That all sounds a little convoluted and tricky, but it mirrors the way that we count influenza deaths. And we've been doing that monitoring for now more than a decade. And we've actually found it really helpful for understanding the true burden of disease. Because when someone is hospitalized with a severe respiratory illness, they may survive that hospitalization, but it leads to an overall decline in their health such that they don't survive the 60 days following discharge. And we do think it's fair to attribute that to the original cause for hospitalization.
Great, thank you. So moving on to testing shortages.
Yes. During the week of July 6th through 12th, we did see a decrease in the number of tests performed. This decrease was about 29%. At the same time, we have been receiving widespread reports of delayed test result turnaround times through commercial laboratories. It has been widely reported nationally that testing shortages are occurring, and because the COVID-19 testing supply chain is national by nature, both national and local case counts are affecting our testing supplies. We do expect worsening shortages as our case counts continue to rise locally and nationally. This is something that we're monitoring carefully, and we do have plans in place for potential prioritization within testing.
So moving on to Remdesivir. Just to give you all an update, there hasn't been any significant new peer-reviewed studies on Remdesivir that's been published since the last time we discussed this all with you. If you remember back in April, there was a study that showed that there was a 31% faster recovery time compared to placebo. So basically 11 days for patients who received Remdesivir versus 15 for those who received placebo. But the differences in mortality were not statistically significant, and the full results of that study haven't been published or peer-reviewed yet. So that's kind of the background on Remdesivir. On July 10th, the manufacturer of Remdesivir, Gilead, did produce some additional release about some of that data. And they looked at different ethnic groups and found that different ethnic groups had similar outcomes to each other. And then another sort of piece of this study that came out is that Gilead, I guess this is a new study, Gilead has announced that they're going to begin a clinical trial to look at inhaled forms of the drug. So there's been some, so in the hospital, we give this drug through an IV. There's thoughts that it might be even more effective if inhaled. If the inhaled form is safe and effective, it may be moved out of the hospital and into more of the home setting, and be perhaps more widely in demand or in use. The company also announced that it's going to start testing the IV drug in children. The previous study had only been in adults. So that's kind of the background on where remdesivir is going in terms of studies and use. As you're probably all aware, OHA received donated remdesivir, a total of 2,680 doses. These have been distributed to hospitals and used at the hospital provider discretion. We don't believe we'll have any further donated doses. We don't expect to have any. The donated doses have been, the distribution is completed, and now what we're working with is commercially available, so paid for remdesivir. The first expected shipment to Oregon from Gilead, we expect to be about 200 doses. We do expect that this is going to become a scarce resource. It's in demand around the country. And just as a final reminder, this does not have FDA approval, so OHA's official stance is neither for nor against the use of remdesivir. Let's see, I'm just going to check see if we have any other questions. Okay, we have a couple questions that we'll hopefully get to toward the end that have come in. I'm going to move on and just very briefly talk to you about revised guidance for PPE in healthcare constrained, resource constrained healthcare settings. So OHA published a revision to their guidance on July 8th. At the bottom of this slide, you'll see a link to where you can get to the full guidance. It's more granular, gives a little bit more specifics in these areas, and includes things like engineering controls, airflow, et cetera, administrative controls, and then a use of a tiered approach to optimize PPE supply. So if you have any questions about the use of PPE in healthcare and resource-constrained settings, please see that link at the bottom of the screen. I'm going to stop right here and ask Dr. Sutton a couple of questions that have come in about testing. One of them was that Oregon seems to have much more limited access to testing than other states. Is there any expectation that Oregon will get a better supply of tests?
That's a good question. So testing supplies are distributed in part by state population and in part by COVID-19 case count. So ultimately, we have what's considered to be a fair distribution of testing supplies. I'm not sure I would say we have fewer per capita than other states, but I would say we don't have enough for our needs at this point in time. We're doing everything we can to advocate for getting additional supplies from the federal government. This is something the governor has been pushing with the Department of Health and Human Services, but unfortunately, supplies are really limited nationally, and with the increasing cases that we're seeing in huge populations in California, Arizona, Texas, and Florida, we just are not a priority right now.
So then what are the options for testing and surveillance?
Yeah, so we have what I would call a robust surveillance system in place. That's something that I actually have designed and lead for the state of Oregon. So we have currently 16 facilities across the state that are doing weekly screening for COVID-19 in both symptomatic and asymptomatic patients, and we are attempting to recruit an additional 4 facilities. We have serosurveillance, so antibody surveillance projects going on. We just completed our first general population antibody study, and those results should be released in the next 1 to 2 weeks. We plan to continue antibody studies quarterly going forward, and we have some studies planned in special populations, including children and long-term care facilities. We have a hospitalization surveillance system that includes 43% of Oregon's population. So every hospitalized case within the Tri-County area has a complete chart review done, and that data is provided to the CDC and is also available locally. We will be implementing wastewater surveillance at 40 sites across Oregon in the coming weeks. So I think surveillance-wise, we have a lot going on. In terms of testing, so right now, we have not yet put into place a prioritization scheme. But if you look at our testing guidance, it actually has not changed from early in the pandemic in that it does list priority groups should resources be constrained, and it does specifically state that disease severity should be taken into account. I think in general, tests are still available at most healthcare facilities across the state. The issue is, of course, how long it takes to get test results. That's not an issue for hospitalized patients right now. We have excellent turnaround time for patients who are critically ill. In the community, you know, we do advise that if you're waiting on a test result and someone has compatible symptoms, treat them as if they had COVID-19, right? Ask them to isolate and do all of the things they would normally do. And of course, reach out to their medical provider should their condition worsen.
And one other question about the data that you shared. Question came in, if a person has multiple tests, like they're hospitalized and they're tested multiple times and they're positive before they get a negative test, do we count them as one case or as 3 or 4 cases?
So our testing data is person data. So duplicated persons would only be counted once. Of course, that system isn't perfect, but it's pretty good.
And there was a question about guidance that OHA is giving schools, and I will let you know that Dr. Sutton and I were both in meetings this morning. That's an active piece of discussion here at OHA, looking at community prevalence and thresholds for school restarting, and stay tuned. I think there's going to be more coming out as OHA and the governor's office kind of, and the Department of Education kind of come up with some final thoughts on that. And then Dr. Sutton, I know this is close to your heart. Someone wanted to get a little bit more information on wastewater surveillance. What does that mean and how is it used?
Yeah, that's a great question and one I love to answer. So wastewater epidemiology has been used for other diseases in the past. Polio, for example. It is newly being used for COVID-19, of course, because this is an emerging pathogen. So across the country, this is rolling out on sort of smaller scales. And the concept is that you can detect COVID-19 at the community level earlier than you can detect it through a surveillance system that screens people. The reason for that is that we believe a significant proportion, whether it's 30, 40, 50% of cases are asymptomatic, and then a significant proportion are mildly symptomatic and don't seek care. Those persons probably are shedding SARS-CoV-2 virus in their stool, even though they are asymptomatic or mildly symptomatic. What we've seen so far is that we pick it up in what we call the waste shed before we pick it up in our healthcare system. So the way that we will be using this in Oregon is outside of the Portland metropolitan area. We have looked at populations that are large enough that we can obtain the samples that we sort of need to obtain. It's a bit technical. And and have a large enough population that it makes sense to deploy it, and that ended up being about 40 sites. The reason we are not using it in Portland is twofold. First, because it's a huge metropolitan area, we do expect there to be a constant signal for some time, so it wouldn't really be informative from a public health standpoint. But second, I think our colleagues at OHSU also have some special studies around wastewater surveillance in the Portland area planned. We are really excited about this, and in general, so we will be creating a data dashboard so that the public can see this information in real time. And we're hoping that providers can use it to say, oh, wow, we've got a new signal and we haven't had one for some time. So when I see people coming into my clinic with respiratory symptoms, I'm definitely going to be on high alert.
All right, let's take a break from questions for a little bit and go through a few more slides. So universal masking in healthcare settings.
Yeah, so I just wanted to bring up that we have discovered a loophole in our guidance. So we do have guidance stating that universal masking is recommended because the language uses the verb should instead of shall. It is considered a recommendation rather than a requirement. So we just wanted to let people know that in the spirit of the governor's orders and in the spirit of good patient care, we will be updating our guidance to make this a clear requirement, and the expectation is that both patients and providers are masked at all times during any healthcare encounter.
Great, thank you. So moving on to the COVID literature updates, I pulled two studies that I wanted to just bring to your attention this week because I think they have some interesting clinical things that we should be aware of. The first is a study that came out in this week's JAMA. It was looking at persistent symptoms after COVID-19. So they included 143 patients. It was basically a cohort study of people who had recovered. These were hospitalized patients. They had, on average, been in the hospital for a couple of weeks, and 7 patients received ventilation. So this is a sick group of folks after they get discharged. That's kind of the cohort that we were looking at. They were assessed 60 days after the onset of their first COVID symptoms. And at the time, only 12% were completely free of symptoms. 32% had 1 or 2 symptoms, and 55% had 3 or more. None of them had fever or signs of acute illness. Basically, what they were complaining about was fatigue, and about half of them dyspnea, joint pain, and chest pain. They did not look at persistent medical diagnoses. I saw a question that came through the chat box about ongoing perhaps cardiac issues or things like that. I don't think there's any literature there yet. This literature is basically that people, particularly people who've been pretty sick with COVID, it seems to take them a long time to completely get better. And so if your patients come in and say, it's been 3 months since I was in the hospital, why am I still feeling so fatigued? You can tell them that's pretty normal, and we're learning about this new pathogen, and their recovery is probably on track. The second study I wanted to bring to your attention, you've probably heard about this through just general news reports, but the official MMR report came out this week. This was about 2 symptomatic hairstylists in Missouri. So these 2 hairstylists were both COVID positive, and COVID-19, not COVID-10. They were positive. They believed that one hairstylist infected the second, probably during breaks or social time outside of work. They took care of a combined 139 patients, and these were significant exposures, 15 to 45 minutes with the hairstylist and the client. Both the stylist and the clients wore face masks. Stylists wore cotton face coverings, or the second stylist also sometimes would wear a surgical mask. So these were most of the time they were wearing homemade cotton face coverings. The clients typically also wore cloth face coverings. A good percentage did wear surgical masks. 5 wore 95 respirators, so hopefully they got those from the Home Depot or not from medical facilities. And a couple didn't know what kind of face coverings they wore, but did state that they did wear face coverings. And among all of the cases, all of the 139 clients, none had any symptoms. 67 were tested and they all came back negative. Just of a note, the household contacts of one of the stylists, which included a couple people in her immediate household and a couple of close family members who lived in a household that frequently interacted with her, they did become sick. So she was infectious, but the kind of the take-home point here is even cloth face coverings appear to be substantially protective for exposure to SARS-CoV-2. So moving on to your clinical care questions. We've been getting quite a few questions about when can a patient return to work after a COVID diagnosis. So all three of these features have to be there. They have to have 72 hours without a fever, without the use of ibuprofen or Tylenol. They have to have their symptoms of cough or shortness of breath or whatever their presenting symptoms. They have to be getting better, and it has to be at least 10 days since their positive test. And if they never had any symptoms, obviously the first two, the fever and the symptoms improving, wouldn't count. So it has to be the 10 days. If you are being asked for an employee return to work now, realize that what public health has been doing is when somebody is diagnosed, they are sending a letter, or they should be sending a letter to the workplace outlining these criteria. And that, when a patient meets all of these criteria, they are, from a public health point of view, clear to return to work. So you don't necessarily have to write them a letter. And then there has been some questions we've been asked about workplaces, particularly asking that people, when they're recovering or asymptomatic people, should get retested. And OHA is saying that there's no need to retest as long as they've met all of the following, all of the criteria that they're clear to go back to work. So going on to sort of another question about asymptomatic people, when should an asymptomatic contact, so this is not just an asymptomatic person out in the world going in for a procedure or something like that, but a case contact, when should they be tested to get the most accurate results? So if an asymptomatic person is quarantined, you don't have to test them. We're basically quarantining them for 14 days to see if they develop symptoms. And if they go through the whole 14 days, they don't develop symptoms, then they're free to go about their life. If they do get tested, it does not negate quarantine. We know these tests are not that sensitive. So we could be missing quite a few positives, so they still need to quarantine. If you look at the studies that look at the sensitivity of the PCR tests, the highest sensitivity, which is somewhere between 70 and 80%, is about day 8 after exposure, or when symptoms develop. That tends to be another place where the sensitivity of the PCR goes up. A question we're still getting questions about antibody testing. So this is the testing to see if you have blood antibodies to SARS-CoV-2. OHA is not recommending this as part of a workup. You can't use it as part of a diagnosis for an acute illness because antibodies may not be present for quite some time, and these tests are very insensitive. We do recommend it as part of the workup for hospitalized people under the age of 21 being worked up for the multisystem inflammatory disease in children. There may also be some use in epidemiologic surveillance. We've had a lot of questions about data on protests and how they've been affecting case numbers. There's no Oregon-specific data on this, but there have been several early studies. I'm just kind of looking at the ecological sort of look at cities. So cities with large protests, some have had large increases in case numbers and some have not. There's no correlation whatsoever between protests and the number of positive tests 2 weeks later in these ecologic big studies. So it doesn't seem like they're a big driver in cases. So I'm going to go back now and look at your questions. A question about face shields in healthcare. Can they replace face masks?
So in healthcare, no, face shields do not replace face masks. For the general population, we do consider them equivalent. Face shields in healthcare are meant to be worn over medical grade masks and provide eye protection that goggles could otherwise provide.
Yeah, and that's different messaging from what OHA has been giving to the general public. We feel that that's a much lower risk if you're just out and about in public, and that the face shields can suffice, particularly for those people who can't wear face masks for whatever reason. Is there any new information about survival after invasive mechanical ventilation? I've been looking, kind of monitoring this data. There have been some reports out that the death rate is going down. The death rate in early March was as high as 80% for folks who ended up on mechanical ventilation, and now it is lower in many areas. This may be because we have some effective treatments like IV steroids or Remdesivir. It may be because of prone positioning, other kinds of oxygenation that we've been doing. But I don't think that there is a clear answer to what's going on there. And hopefully we'll start to see some literature coming out with best practices about folks, how to help them kind of through their really acute illness. Then there's some questions about does OHA and or local health departments have oversight and review for university and college opening plans or for school opening plans?
We are collaborating with the Oregon Department of Education and I'm not certain the name of the agency that regulates higher education, but we are working with both of them on their reopening plans.
Is it viewed as a positive that the case rate's growing, but hospitalizations appear to be flat? And what do you think is causing that?
So hospitalizations, I would not characterize as flat. They are slowly increasing. I did hear a number floated earlier today that they're increasing about 1% per day. Again, the reason we're not seeing a dramatic increase in hospitalizations with the dramatic increase in case counts is because we have more younger people sick now being diagnosed as cases, and they do not get as severely ill as older populations tend to get. Of course, there are exceptions.
Can you address decisions to move data collection from the CDC to the new HHS server, and how will this affect OHA data reporting, access to data for the public, etc.?
Yeah, so the data in question is hospital capacity data. This is data that is on our website. So the metrics you'll see are the number of hospital beds available, ICU beds available, PICU, NICU, the number of ventilators available. This is reported by our hospital partners in Oregon directly to OHA, and that remains a reporting option with the new guideline that is going into place. So we do not believe this will affect our data collection in any way. It will absolutely not affect our data transparency. We will continue posting this data, updating it daily on our webpage.
And I think that's the same for many, many other states have sort of internal reporting. So hopefully we'll continue to have pretty transparent data around the country.
We hope so.
There was a question about cardiac impacts of COVID-19. I don't have anything at my fingertips. We can try to bring that back and do some looks to see if there's anything out there for our next talk. A question about, in a household with a positive case, when do we start counting the days of quarantine for the other asymptomatic people?
We start counting the days for quarantine from the date of last exposure. So that's a tricky question. If you have a household with one case and that person is able to isolate, then you can begin counting quarantine from the date of isolation. And I mean, by isolate, I mean someone can stay in their room with their own bathroom and not interact with other members of the household. If they are not able to isolate within the house, the quarantine period begins the last day of that case's isolation period. So essentially on day 10. So household contacts end up being quarantined for 24 days total because their exposure goes on throughout the 10 days of isolation. And that is a very painful thing for households.
What % of cases does OHA estimate are caused by aerosol versus droplet transmission?
That is an area of active debate, and we do not have a stance on the proportion. We sort of feel like it's splitting hairs. It's really a continuum in terms of how large the droplets are. We certainly know it looks like there's some evidence of aerosolized transmission. There's probably much more droplet transmission, but it's really a continuum.
Then there was a question about use of heparin and other anticoagulants. I haven't seen any recent data on this, but we can look for that for next time, unless Dr. Sutton, if you...
I haven't seen anything new. I know only that they're being used commonly.
Right, okay. That's pretty much all of your questions. Like I said, we will try to answer. It sounds like there's some interest in looking at things that can help people survive when they have severe illness, possible heart long-term effects. I do apologize. I know at our last webinar a couple of weeks ago, we promised to bring you some information about how the state is helping our migrant worker population. We weren't able to get that together for this week, but we'll keep it on our list of things to bring back and share with you all. So we're going to give you back 15 minutes of your day. Continue to send us any questions that you have. You're welcome to just briefly, just want to remind you all of the ECHO sessions. There's going to be an ECHO session next Thursday, same time, noon on Thursday. And we are going to continue to do our OHA ones on the first and third Thursdays from noon to 1, and then kind of to swap out with the ECHO, who are doing the second and fourth Thursdays. And, oh, I apologize. Normally we have a slide on here with the address where you can give us questions. But if you do have any questions, please go to our website, and you'll find a link where you can submit questions to OHA. Oh, I'm seeing a few more questions. Let me see if we might be able to go through one or two of these really quickly. What is OHA doing with community messaging versus about face coverings? I know OHA has a bunch of stuff on their website. They have some really cool infographic-y kind of things that you can download. There's lots of things going out on social media. I know the governor, when she does her press conferences and other kinds of venues like that, there's been a lot of information and encouragement about face masking. Healthcare workers with antibody surveillance studies. I saw this question came up a couple of times. The antibody surveillance studies, I believe, are being run through OHSU or maybe OSU. I don't think that OHA is directly involved in those.
So I'm actually running the antibody studies.
All right, Dr. Sutton has all the info.
We do not have a dedicated study in healthcare workers. There are a lot of sort of smaller informal antibody studies going on within the healthcare systems. We do have a study that will actually be interviewing healthcare workers who are cases and checking their medical records for antibody test results. So in sum, at this point in time, we won't be collecting antibodies only in healthcare workers, but that data is being captured through our partners.
And one other question about testing. Given the fact that we are having some testing constraints, will there be testing prioritization plans? Basically, are there groups that are going to have tests run more quickly?
Yeah, so this is a really active conversation. It's important to us that this is done in the most equitable way. We have not yet determined that prioritization is necessary, but we're watching this market really closely. In general, we know that symptomatic patients will be prioritized before asymptomatic patients. And within the symptomatic patient category, should we have additional constraints, disease severity, and priority populations, which are listed in our guidance and include the elderly, pregnant women, vulnerable communities, those with underlying health conditions, frontline workers, those would be prioritized as they were early in the pandemic. Again, we hope we won't reach that point. We hope that we will continue to be able to test at least all symptomatic Oregonians, but we do have a framework in place for prioritization.
A question came in about, can you compare US numbers to European numbers, especially European countries that didn't close?
Yeah, so the only country in Europe that has had a higher case rate than the United States is Sweden. And this data is about 10 days old, and it is from the New York Times, so take it with a grain of salt. It's media biased, but my understanding is that Sweden per capita has had 40% more cases, had 40% more cases than the US as of about 10 days ago. Otherwise, we have the highest per capita rate that I'm aware of.
Where are we with a vaccine? That's a great question. I would love the answer to.
Yeah, so right now we have a large vaccine project that's moving into phase 3 clinical trials. I think this is going on at several sites nationally. I'm most familiar with the site in Seattle. The results of the phase 1 and phase 2, I believe, were just published this week in the New England Journal of Medicine. And I know that the results were what they had hoped for. I think that in general, the optimistic estimates for vaccine development were 12 to 18 months from the beginning of the pandemic, which puts us at next spring to fall. Those are very aggressive estimates. It remains to be seen if we can meet that.
Yeah, and if I remember the New England Journal articles correctly, the vaccines they were testing showed they were both safe, they didn't have any major adverse effects, and that people developed antibodies. Of course, we don't know if that would be protective against infection. That's the $100,000 question, but reasonably positive for what we can hope.
Yeah.
What's the status of contact tracing adequacy in terms of resources with the local public health departments? Do we have any information on that?
So we have hired, for the most part, the number of contact tracers we thought we needed. And what I can say is that as case counts rise, counties are increasingly feeling the burden of that, and it will affect the timeliness of case investigations. They are doing the best they can. Unfortunately, some of our hardest hit counties right now are rural counties, And so, they of course have smaller staffs, and that burden is significant.
Great, thank you for all your great questions. One last question that just snuck in. What about the new evidence showing immunity is not as long lasting as hoped after an infection?
So I believe you're referring to detectable antibody levels, and what we don't know is how that translates into whether or not you will get sick. Because it can be that we don't detect antibodies, but you are protected from the disease. So what we really need is that missing gap. So do you have antibodies? Yes or no? And for both, will you develop illness within a certain period of time? And we won't have
develop illness.
Develop illness again. And only time can tell us that. It's an area of active research.
Yeah, and I've also been seeing there's a lot of active research into T cells as a source of immunity. So, and then, is there any type of case management once contacts have been traced?
So case management for contacts, generally speaking, so it depends, I guess. It depends on the scenario. So persons under monitoring, we call them. So those are contacts with significant exposures. They are given a lot of information and asked to check in immediately should they develop symptoms. Some counties do have the ability to reach out to those persons under monitoring regularly. Others do not.
And then I did see a comment from one of our listeners talking about the fact that they really appreciated the epidemiologic slides and information. I wanted to know if those could be added to the ECHO presentation. The ECHO presentation is through OHSU. We'll give them that feedback, but OHA doesn't specifically have a lot of control over the content of that. But we will at least make sure we include those for you every other week so that you can stay abreast of the latest. Great. Well, I was going to give you back 15 minutes. I'm now going to give you back about 5. Thank you so much for joining us. I hope that this was useful for you all. And we will be be with you all again in a couple of weeks.
Thank you all for your hard work. We appreciate it.